Yeah, I think it's okay. We just need the. Well, thank you for coming. My name is Ibrahem Hanafi. I work with Professor Isaias, and today I will be talking about the brain metabolic activity during gait in Parkinson's disease. In the last few months, I presented one lecture also about the electrophysiological brain activity during gait in the SCN and GBI. So I will go on the introduction very fast. Why is it important to study gait? Because patients die due to the gait problems. So the more difficult answer is that gait problems induce gait fractures, either muscle weakness, and then more postural instability and a vicious circle, or in the direction of more social isolation, cognitive impairment, and then freezing of gait, and then also more falls. As a result, it induces mortality, poor quality of life, and a loss of independence. Gait is impaired in all the parameters that we can measure for gait. These are the control subjects, and these are the Parkinsonian patients, and we can see that, for example, the swing time is increased, the step velocity is decreased, and so on. In addition to this, there are freezing of gait, which is an episodic brief inability to produce further steps. So, are we able to treat Parkinsonian patients who suffer from gait problems? It's not, our treatment is not really effective. You can see here the different parameters that we can collect for gait, and we can see here that for some of them we can improve, like stride velocity. However, for most of them, we either are crossing the no effect line, or we are inducing worsening. On the other hand, DBS is able to improve gait. For the first deep brain stimulation is able to improve gait in the first 6 to 15 months, but then we can see a worsening over time. And this happens for more than 60% of the patients. However, it is supposed to be more effective for gait because we know that it targets a specific nuclei, and then it doesn't change the whole network, but it can be more specific in the targeting. Usually we target the SCN or GBI, and the limitations are also known, partial efficacy and the cost. The SCN and GBI are equally, like, this is a systematic review of long-term, like 5 years effect of deep brain stimulation between the GBI and the SCN. We can see that there is no significant difference between the two targets. So we want to study the brain metabolic activity, but why the brain? Why don't we study the metabolic activity in the spinal cord, which has also been done? First, like, in contrast to animals, to animal models, gait in Parkinsonian patients need the supraspinal network. And gait modulation, for example, is impacted by strokes that affect the frontal lobe or the parietal lobe. BD is a brain disorder, so it makes more sense to study the brain, and also deep brain stimulation can be effective. We say not in all patients, and it doesn't last for long, but can be effective. So we can start with the supraspinal locomotor network. Then, why the metabolic brain activity? What does it mean? And why don't we stick to the electrophysiology that we can see here that has a higher resolution, temporal resolution? Why should we go to the PET scan which doesn't have this temporal resolution? Because these are the metabolic brain activity. fMRI and fMRIs can collect the functional networks in the brain. However, there are indirect measures of brain metabolism. And on the other hand, FDG-BET calculates the consumption of glucose in brain regions, which means it's a direct measure of brain metabolism. Similar to this is the H2O BET, which studies the consumption of oxygen in these brain regions. Okay, then if we want to study this metabolic brain activity, what do they offer us? They offer us more than the EEG and MEG and so on, more subcortical definition, because we don't want to only study the cortical lesions, but also the subcortical lesions which we are targeting. And also, between these two, we can see that FDG-BET offers us the possibility of doing actual gait instead of doing just the studying gait imaginary or whatever. So if we stick to the FDG-BET to reduce the amount of literature we are revising today, this is the molecule that we are talking about, and an additional benefit that it offers us that it is less sensitive to movement artifacts when the patient is in the scan, and this is in contrast to fMRI, which is the most common way of studying the functional connectivity. So, brain cells work more than they consume more, like people. People eat more to work more, or they work more to eat more, but they correlate with each other. So the synaptic activity correlates with the glucose they are consuming. However, there are food that we consume but we do not digest, and this is similar to our molecule. So brain cells take this molecule, it gets trapped in the cells, but they are not able to consume it, which makes it radioactive, and then we can measure it. We have the brain, the patient comes to the lab or to the nuclear medicine department fasting. So the brain is waiting for the sugar, then the brain gets the sugar, and after 30 minutes, we put the brain in the scan and we see where the metabolic activity sits. Okay, so they studied first brain metabolic activity in Parkinsonian patients compared it to healthy subjects during rest, like the patient is not doing anything. And you can see here that there is hypermetabolism in the cortical regions, more hypermetabolism in the sensory motor area and in the cerebellum. The expression of this, so it is not one region, it is a mix of regions that is hyper or hypoactivated. And this is mostly related to the severity of rigidity, one of the most important symptoms of Parkinson's disease. And not, for example, to tremor. The tremor has a different network. However, this is the most important, and that's why they call it the PD-related pattern. This PD-related pattern, the expression of this pattern is hindered by the treatment. So you can see here that this is the pattern when we do the retest between the subjects or in the same subject. Lesions to the brain doesn't affect it very much. Then the STN lesion or deep brain stimulation reduce this expression, and also levodopa, which makes it an activity that is related to Parkinson and also that is modulated by the treatment of PD, which makes more validation of the regions that we see. Then we need to know if this is a genuine pathology or it is a compensatory mechanism to the pathology of Parkinson's disease. And to do this, we will have 5 steps. First, we can categorize PD patients into groups, and we see the differences between the groups and between these groups and healthy controls. For example, there is one group of or subtype of Parkinson's disease, the postural instability. Those patients have more axial involvement. So They are more involved for gait and axial symptoms, standing from the chair, for example. And we compare them to tremor-dominant Parkinsonian patients. And we can see here that there is some regions, but for example, first we can compare, this is the posture instability and gait-dominant Parkinson's disease to the healthy controls. And you can see hypometabolism in the caudate nucleus and in the frontal and parietal areas. This is understandable, as we saw in the previous slide. When we compare two regions, when we compare two subtypes of Parkinson's disease, we see different regions, which makes us understand that these patients are not exhibiting the same metabolic activity in the brain. So, and then these hypometabolism, which are expressed here, they are focused around the anterior cerebellum and the posterior part of the cingulate gyrus. Then, can we use these activities, these regions that are hypo or hyperactivated metabolically, to transfer to other modalities of studying the brain? Yes. For example, in this study, they took these patients, they did the PET scans during resting, and then they did also fMRI. And they saw that the PIGD symptoms, the clinical assessment of PIGD symptoms correlates with decreased frontal parietal connectivity. So these regions which were hypoactive, which had high metabolism in comparison to healthy controls, they are also responsible. The connectivity between them is responsible for the PIGD symptoms. So we are able also not only to, and this is the correlation, not only to define areas, but also to correlate the activity of these areas with the symptoms. So can we do that also with PET activity? And yes, we move on to the second step, correlate with pathological signs. Like the patient is exhibiting different symptoms to different severities as well.
Yes, if you just go one step.
Yeah.
This correlation.
Yeah.
I mean, when you're doing a correlation on that, then you get that correlation. But how sure is this a correlation?
Yeah. So,
I mean, what's the probability that's unlikely that this correlation is true?
So actually, this is one of the very first studies, and this was confirmed by the next slide that will come. So I understand that you see that the coefficient of this correlation doesn't look very strong. And this functional connectivity between this area is also, but actually what they did is they studied the correlation with other symptoms. They found this is the most significant, and they concluded that these regions are more correlated with PIGD symptoms. I understand that it is not the most robust, but this was replicated by the next study that will come.
Can I ask another
Yes.
question? When you showed the data, was it also already with gait? Did the patient walk and crawl?
No, everything till now is just during rest. And this is one of the things that will improve in the next slides. So, correlate with the pathological signs or with the severity of the symptoms. For example, patients with freezing of gait versus patients without freezing of gait. And we can see here that there is hypometabolism in the frontal and parietal areas. These are two studies, also very old studies. The second one is not, this one is not very old. And we can see here also, this is replicated by also temporal or parietal areas and occipital regions, in addition to the correct caudate nucleus. Okay. Can we take this further This study is very recent, and what they wanted to study, and this is one of the most robust ones. So they took 55 early-stage Parkinsonian patients and 20 age-matched healthy controls. They made them walk for, and this was retrospective, but still, they made them walk for some rounds, and they extracted a gait model. So gait variables like pace, rhythm, variability, 12 of these parameters. Then they collected only the 55 patients who had PET scans. And they took these PET scans, reduced the dimensionality of these PET scans, and showed that there are different principal components in these PET scans, in this activity. Principal components means some network, some co-activation, activation in one area, deactivation in another area, and so on. These principal components, they took just 10 of them, which explained 75% of the variability between patients. In addition to this, there was 20 age-matched who did the same study, and they had also PET scans for other reasons. Then they wanted to study if any of these gait models correlates with the expression of any of these principal components, of any of these co-activation or metabolic patterns, let's say. And what they found is that there was a network called base gait network, and it showed a correlation between the mean step velocity, mean step length, and this pattern of activation. You can see here that this pattern is a mix of the cognitive areas and also locomotion areas in addition to the cerebellum. It makes sense. Then they also found another one, which is the temporal variability gait network. And the two parameters were the swing time variability and the step time variability. These two measures were predicted or were correlating with the expression of this network, which are also more dispersed, but they are all connected to the nucleus of minors, and this gives us the idea that it might not be that gait is only related to the dopaminergic innervation of the brain, but also can be related to the cholinergic function. The nucleus facialis of minors also connects to these regions and stimulate them with the cholinergic connections. The expression, yeah.
In these gait tasks, also if you do it, for instance, with animals, you can have whatever 58 variables.
Yeah.
How likely is it then that they just take any of the variables?
Yeah. So exactly, they tested all the variables. They had 12 variables. They tested with a mixed regression model, some complex statistical method. All the expression of the 10 principal components of the PET scans that explain the variability between patients in the PET scans, and the expression of these 12 parameters. And they found these combinations, only these combinations. Then they actually, to validate this, they took that pattern of activation and applied it and showed how it is expressed in healthy controls.
I fully understand the complete methods. A little bit is my worry when you go in these rather variable data, in a rather variable assay, and link that arithmetically on 58 dimensions, 100 dimensions, 12 dimensions, that it's just When
Yeah, so we can say
more or less, if you have so many parameters, and then you select from these many parameters 12,
yeah,
for instance, and then you say, okay, these are now the main parameters. Then these are still 58.
okay.
Yeah, because you have done a pre-selection. So meaning, if you would go into a statistical analysis, the likelihood that this is just random is extremely high.
Okay, so but if you are taking these 12 elements,
I mean, I'm just saying that because the same was done for pain and for many other areas since, let's say, 20 years, and not even pattern was really.
yeah, I understand. And actually, one of the main conclusions of this presentation will be that there is very high heterogeneity. Even when you are asking the patient to do the same task, there is also some patient expressing like completely opposite direction of the activity. But first, we can say if there are 12 parameters, 4 of them are different between, actually 5 of them were different between healthy controls and Parkinsonian patients. So we know that there is some pathological pattern in these 5 parameters. And then these 5 parameters are connected to an expression of 2 patterns. And these 2 patterns are expressed in Parkinsonian patients more than the 20 control subjects. And this expression of this pattern is correlating with the how much they deviate from the healthy subjects. I think it would say that we can at least rely on them. Don't you think so?
Did they maybe try and validate it with a separate cohort of patients?
No. Yeah.
I mean, sure, it's published, so we have to take it as it is. I'm just wondering because of the areas that are active. So if you do certain peer essays, motivation essays, whatever you do, you more or less get the same regions. And I have the impression whenever we are looking to this kind of data, what always pops up is insula, nucleus accumbens, amygdala, and so on and so on. So that we have so many regions that form a pattern. The patterns are drastically overlapping, and they're rarely reproduced.
Yeah, but I don't know if there is any other method, because I found like this method was one of the most reliable between the papers that I'm presenting.
Yeah.
Okay,
I mean,
but still they're not ideal. But
why are you insisting on that? On statistics, variability, stability, and so on. That's very practical reason, because we try to mimic this in rats or in mice. So meaning we are looking for these brain regions, and then something pops up, like insula, red nucleus, so on, which never pops up in our.
Yeah. I understand it's a limitation, but not of a single study of the whole field. Okay, and these activation, when they added to the regression, the other components, the total severity of the disease, the levodopa equivalent daily dose, and also the cholinergic burden, they were unrelated to the expression of these patterns. Then we can try to normalize the behavior, giving the patient medication, adding the stimulation, or doing rehabilitation, and see what changes in brain metabolism. For example, in this study, they did gait rehabilitation. It was an acoustic auditory cues to help them have more rhythmic gait pattern for 4 weeks. I'm sorry, for 9 Parkinsonian patients. They contrasted the metabolic brain activity between these Parkinsonian patients before the training and to the healthy controls, and they found hypometabolism in the bilateral and the frontal temporal, the cortical areas that we showed before, that there are their hypometabolism is correlated to gait severity, and hypermetabolism in the left cerebellum. After the rehabilitation, we can see that there is more activation and more metabolism in the right cerebellum and the right parietal and temporal lobes. And we can see that the variability of gait is reduced. Very small regions, and also like they are not related to the specific areas that were shown in the previous in the comparison between pre to the healthy controls. Then, if we look at deep brain stimulation effect on freezing of gait, deep brain stimulation was effective for this group of patients, and it induced hypermetabolism in the parietal temporal occipital areas, also cortical areas, and this activity correlated with the improvement of freezing of gait. That was a clinical assessment of freezing of gait. So we can say that also these cortical regions are related to the expression of freezing, and when we are treating freezing, they are more activated. But this study did the opposite. Deep brain stimulation in some patients induces freezing of gait and axial symptoms. And we can see here that they collected some patients, 56 patients, who had PET scans 3 months before and 3 months after surgery. And these patients had a decrease, or an increase, 2 more points on the clinical assessment of the IGD, meaning these patients in 1 year from surgery, the clinical assessment was before surgery and 1 year after surgery, they had induced a freezing of gait, but they focused only in the infratemporal region of interest. And we can see here that there was a hypermetabolism after DBS in MLR, PDM, right motor cerebellum. These areas that are thought to be responsible for the improvement of gait in other studies. So still, the same region might pop up when we are inducing freezing of gait and when we are reducing freezing of gait. And there is still a very high heterogeneity in this. Then another method is, can we predict events that will happen afterwards? Because till now, we are looking at activation pattern that is associated with the symptoms or what we are seeing. And we can't say if this is compensatory, if it is an activity that is related to the pathology or whatever. In this study, they collected, Professor Isaias actually, collected 11 patients who had falls, and 19 patients who did not fall, 12 patients who are healthy controls, taking PET scans for other reasons. This was also retrospective. These patients were just 11 because they selected only the patients who had a first fall episode about 6 to 8 months after the PET scan that was done. That was also a resting PET scan. And they saw that there is hypermetabolism in the left posterior parietal cortex and hypermetabolism in the cerebellum. They relate this activity to altered cortical processing of the spatial body, the orientation of the body in the space. Okay, this was the only study that correlated metabolic brain activity to events that happened after the PET scans. Then all of these have major limitations, and also the next one will have, but at least less limitations. So they saw this guy, took some patients and studied them in 2 different methods, fMRI and PET scans. In the PET scans, it was an unperturbed gait. The patient got the injection, as we said, and then there was 30 minutes. In these 30 minutes was going forward and backward, and they scanned him afterward. And we can see an activation in the primary motor area and the cerebellum. And they saw that they say that this unperturbed gait represents the direct pathway from the primary motor cortex, including also the input from the thalamus and the cerebellum to the spinal cord. The same patients underwent fMRI, and in the fMRI, the patient can't walk because he's fixed in the scan and they can only imagine it. In their imagination, they try to stop, accelerate, and then walk for a few steps, then do another round of, and all of this was in the imagination, stopping, accelerating, and then gait. And they say that this is unperturbed. Of course, there are better ways of studying, this was perturbed, sorry, and there are, of course, better ways of studying it, but they saw that the basal ganglia, the supplementary locomotor region, the mesencephalic locomotor region, are more activated in these regions. How do they exclude that this is only an effect of the scanning settings? Because they did also, both of them, FDG and fMRI in the same patients during rest, and they saw comparable results. And they conclude this, that the basal ganglia are more activated, more involved in the perturbed gait. This is another study that used a treadmill with a split built treadmill. So one built of the treadmill was going, either they are going in the same speed, and then the patient is walking normally, and then they try to continuously modulate the speed of one of these split belts. Then the patient is walking, but he is perturbed because one leg should go faster or slower, and they kept a continuous adjustment of the speed. And they saw also hypermetabolism in the sensorimotor area and the cerebellum in the precorneus. Okay, these two regions, like the sensorimotor region and the cerebellum, are activated in all these studies, but we should focus here that these two studies were done on healthy subjects. Okay, if we take these two Parkinsonian patients and use the same method, and this is the answer to you, Colette. From here, everything will be, patients will get the injection, they will do the task, and then get to the scan. After 30 minutes of doing the task, gait modulation, whatever, and then get to the scan. And this is planned to exaggerate the effect of gait, because till now we're saying, okay, this is the activity during rest, and we are correlating it to the activity, to the symptoms that are expressing themselves during gait. And they found the same regions, sensorimotor region and the cerebellum, of course, also some visual regions. In addition to the PET scans, they collected high-density EEG, and they show that these regions are also hyperactive in the electrophysiological aspects, and their connectivity, for example, the precorneus and the SMA in this region, their communication in the functional connectivity in the high-density EEG was also correlating with gait performance. So all these studies, they understand the limitations. They are trying to take the regions and also validate it in other methods, like we saw in a previous study, fMRI 2 times, this time EEG, and so on. And this was unperturbed gait. The patient was walking in a circle for 30 minutes between the injection and the scan. Now, perturbed gait versus rest. And in this study, they enrolled some patients with freezing of gait, some patients without freezing of gait. The protocol that you can see here, that the patient was getting the injection, the patient was doing some gait modulation. Because what is the meaning of perturbed gait? Patients who are freezing, they are mostly freezing when there is a narrow path that they should cross from, or when they are turning right or left, and this is what they want to see, because freezing of gait is a major symptom, and it's not easy to trigger it. And they were triggering in this manner. For 30 minutes, the patient is going through this small area between the two chairs, turning for some turns to the right, turning sometimes to the left, and then going back. Also, in addition to this, when they are going back, they are doing 100 -3, -3, -3. So they are doing like a dual task to increase the challenge for those who are not freezing with the normal chair task. And we can see here a difference between the freezing of gait group and the non-freezers. We can see more activation on the occipital area and the paracentral area, and also more involvement of the basal ganglia. When they compare the two groups, we can see here those who are having freezing of gait has less modulation of these areas. So you can see here more metabolism in the paracentral lobule. Sorry. Yeah. So this region, which is hyperactivated in both groups, it was less activated in the freezing patients. And also that happens, so less metabolism in the frontal region and hypermetabolism in the paracentral lobule. And they are saying these patients with freezing of gait are having a shift of activity from the frontal to the paracentral. And this is not very robust, because we can see in the next study, they also took a group of patients with freezing and without freezing. The first task was doing normal gait. The second task was going around these regions, and they were changing the colors of these cones, so they have a more challenging aspect. And in this, when they compared the freezers to non-freezers, they saw the opposite, like increased activation in the supplementary motor area, which is in the frontal lobe, and less activation of the posterior parietal cortex. And this is exactly the opposite to the previous study. And they found also major difficulty in understanding why it is completely the opposite. It can be due to the task, because the previous task was a motor task. At the end, the patient, it was actually a mix, because 1/3 of the task was also the patient was calculating, but they were doing 3 different tasks during the going through a pathway, then turning, and then the dual task. In this task, it was more cognitively difficult for the patients, as you saw from the task here. So, and that was also inconclusive, because these regions were opposite to the other study. So what can we do with all these contradicting results and so on? If we want to think about what can we do, first, the metabolic activity in PD, we have it, like different studies, like more than 10 studies, showed the same deactivation of the cortex, more activation of the basal ganglia. Modulation of gait, modulation during gait. What gait is inducing hyperactivity in the paracentral sensorimotor area and the cerebellum, this is robust, but how it is changing during the task, this is not absolutely defined. And modulation by deep brain stimulation we can see that deep brain stimulation during rest there are more studies. During gait we can see only this one study, to my knowledge, that showed more cortical activation, and I mean just during gait, and modulation during gait modulation, meaning the different metabolic activity of the brain during gait modulation or gait perturbance, as we saw in the last two studies, and this is inconclusive. If we put all of these together, at least we need to do more of the overground gait, because it exaggerated the areas that we know that are more activated during gait, and we need more standardized gait modulation tasks, because there were different tasks, they were having different results, and we don't know when they are comparing their results. And this is what we did. The task that we did. May I ask if any of you was here in the last lecture and knows the protocol? I know, like many of you know the virtual reality, so I don't talk about it. Okay, anyone wants me to talk about the virtual reality paradigm? Okay, so the patient is walking and this virtual agent is coming across his pathway. And we did 3 times, 1 time during lesson, 1 time during, or 2 times with obstacle avoidance. This is the obstacle. And 1 time with sim off, 1 time with simulation. So we are combining gait modulation and also simulation, the effect of the simulation. Yeah. During this task, you can see that the patient is walking over ground with the virtual reality visor on the head. So we excluded the limitations of previous studies, hopefully. And in addition to this, we are measuring the with accelerometers, the kinematics of the movement, and with EMG groups, the muscular activity. Why is it important, this virtual reality task? Because it's standardized. This virtual agent only worked when the patient is only 3 meters away from the virtual agent. And it is always happening in the same method. So the patient is not 1 time facing a man with a different color, a man coming from a different direction or whatever. It was always the same man, and coming in the direction of the patient and crossing 1 meter ahead of the subject. And this is the most standardization that we can do. So we hope we have to have more robust findings. We included 12 patients, and we co-registered, normalized, smoothed using the SPM 12, and then we report only clusters above 50 voxels. The first slide is a comparison between the obstacle avoidance without stimulation and resting without stimulation also. And we can see here the same 2 regions, the cerebellum and the paracentral area, and hypometabolism in the orbitofrontal cortex. When we are comparing stim on to stim off, and this is something that was not done before, like the effect of stimulation during gait on the metabolic activity, we can see hypermetabolism in the left superior frontal gyrus and the left thalamus, and in addition to hypometabolism in the right cerebellum. Then, as other studies did, we want to see if these modulations correlate to the activity of clinical severity. So we took volumes of interest, spherical volume of interest in every region, centered around the big voxel, and we calculated the standardized uptake value ratio, meaning the uptake in this region as a percentage of the uptake in the whole cortex. We will start with the 3 regions of that were activated or deactivated in the obstacle avoidance task, and we can see any correlation with the BIGD a clinical assessment or the total UBDRS, so the total severity of Parkinson. And when we are taking the effect of stimulation on obstacle avoidance, so the second comparison between stim on and stim off, both in obstacle avoidance, here we can see that there is more of a pattern for the three regions in the regarding the BIGD improvement, so meaning the patients who are improving more in the axial symptoms in the BIGD items have more induced activity of the left thalamus and left superior frontal gyrus. There are two patients who are expressing hypometabolism in these regions. And if we exclude them, we have more robust results or more positive correlation with the correction for question is 5. We still do not know why these two patients have hypometabolism, but I think we might check that with the EEG, with other methods, see what we can find about these two patients. As a conclusion, we showed the metabolic activation pattern. This was one of the most robust sensory motor area and cerebellum. That was also found in healthy subjects. Deep brain stimulation induced hypermetabolism in two regions, the left superior frontal gyrus and the left thalamus, and the increased activity in the left thalamus correlated with the improvement of axial symptoms. We still need to include the EEG, local field potentials. It changed from the clinical severity as assessed by the clinician with the UBDRS to more kinematic measures, robust kinematic measures that are collected using the accelerometers. And this is important. I think this is missing because only the one study that we discussed were calculating these 12 gait parameters, but all the other studies were either calculating how long the patient was freezing with a stopwatch or something, or the clinical assessment. And this might also be a reason for this heterogeneity. And we still did not control for lead localization or stimulation parameters. And thank you very much. I understand.
Maybe I can.
Yes.
Sorry, go ahead. Yeah, so then it seems like the metabolic activity changes that you see here in the patients, you said it's naturally to what was previously shown in the healthy controls. So they didn't have any perturbation in the system, or?
So actually, the last 3 studies I presented, all of them were walking and were walking in a perturbed setting. Mm. So, yeah, but these 2 regions are hypermetabolic even when the patient is walking without the perturbation. Okay, so this is something that we need to still think about. These results. First, our group is 12 patients, only 5 of them showed freezing. So it is a mix, like these results are still a validation that these regions are correlated with the task, meaning they were correlating with the BIGD, the axial symptoms, but not with the tremor, for example, rigidity or bradykinesia. But still with the help of Professor Mutaraman and Muto, we will have the actual results, meaning kinematics, and then the regions that are correlating to the paradigm, to the gait modulation. But meaning, to start with, the results of the 3 studies are showing the same regions, but how they are differentiating between the groups of patients, how they are different between patients, this is still a question, a large question. But as I said, For the other two studies, it was less standardized. The patient was doing either 3 tasks in the same PET scan, and we have 30 minutes. We are reflecting one image, and this one image should reflect 3 tasks and the gait, which is not the most easy correlation to draw. The second is more involving the cognitive, like the task they were showing with the cones, and the patient is identifying the color of the cone, either going around it or going, I would freeze in this situation, I would freeze. So I think our gait modulation might be, in my opinion, I'm absolutely biased, but it was always the same virtual mom coming in the same direction, crossing at the same point, and the patient was doing 30 minutes, the same exact task. Yes, Colette.
So when you showed the reason of it was like at the page 25, you said that the reason of or the difference would be explained between the different tasks. But can it also be because they are different stages? Like this is like, I don't know when the reason of it does not break that.
Okay, so all of these studies, when they include 2 groups, freezing group and the non-freezing group, they try to control for the severity because it changes a lot. So all of these patients will have the same age, like they are age matched, gender matched, and also regarding the severity. Some studies even control for more disease duration, levodopa dose that they are taking, and so on. So it is less likely that it is related to the severity of the disease.
How about environment?
These patients are doing exactly the same task.
Not during the task, but probably live in example.
Yeah. So it is actually a matter of the ratio. So we are having one image. The patient is doing this demanding task. It is less likely, let's say, that other factors like noise, like a problem at home is affecting the activity. It is absolutely possible, but and like the patient is focused for 30 minutes on doing it's just 30 minutes, patient getting the injection and doing always this thing. I think it's less likely, but with this temporal resolution, we can't do anything.
And another question was, you showed like images where one, it was like the one had to imagine the view.
Yes. So the fMRI. With the fMRI, we can't do actual gait because the patient needs to be in the scan. Yeah. And the question?
So which in the FTG the patient actually walked, right?
Yeah, in the FTG back, the patient was doing only gait forward and backward. Imagination of bursts of gait, like out of gait. He stops in his imagination. He stands for a few seconds, then imagines the gait initiation, then acceleration, and then reaching a point, stopping, then imagining the same thing again.
Other brain areas might be activated that actually have nothing to do with gait, and then show that.
Yes. Like it is possible. It is possible that these regions that they saw that there are more subcortical activation are not related to the gait task, but still also the patient is imagining gait during the task. So it is more likely that is related. Like, what is important here? Like, when they were lying, they were asking them to imagine sitting, and these patients were actually sitting. This is a limitation when we are translating between these two methods, because there are 2 different days doing 2 different tasks, imagining or whatever. But still, like, if we translate this to here is the comparison between gait and rest. Here, the comparison between rest and perturbed gait and normal gait. These, I would rely on these more, and still these are showing conflicting results. So this is the amount of, like, I revised all the FDG bets. These are they, and this is what we can rely on. And still, it is the only imaging task that we can do. We can capture gait. Yeah. Yeah, it is possible. Yes, Hazan.
So it's some question, but I will add it to your last slide and the conclusion of what we need to do. And what I think in general the imaging next is a specific refutable theories that we can refute with, or possibly investigate this imaging. So relying less on the driven and more on the hypothesis driven of to exclude or to disprove a certain theory. I think in general this is not it's less in the field of neuroimaging is less than other fields. So I think this could be added as something we need to do in general.
Yeah, actually, it's a very important point. However, there are 2 of these studies who try to do this. They say we have a hypothesis, we try to test the hypothesis, they find negative results, and they return to this one. So they are still doing the same, because when they are with this heterogeneity, the hypotheses that are imagined before the study are largely not met, as also Professor Bloom said. So we can't. It is absolutely a recommendation that we need to do, but practically it's hard to implement.
I mean, the actual question is, what is a good experiment? I mean, as Colette just pointed out, imagination. Is that a good experiment? I'm imagining jumping versus gait versus swimming versus whatever. We will always more or less, I mean, it's a prediction. Get similar results. And, yeah. I mean, it's not easy to implement. Therefore, I'm so also astonished that they put so much effort in the scanning without having a good experiment. I mean, they are not freezing in the scanner. The field, whether it's the mouse research or the human research, is suffering from the problem that when we are looking at an effect, that the effect is not there, and the effect is freezing of gait.
I think that's extremely difficult to put them in clinical or experimental setting to make the patient freeze. It's extremely difficult. I think the task that Ibrahem showed is one which we have an experimental setup where they do exactly the same.
You come closer to the
exactly, and then of course we think you guys won't have the healthy subjects, but at least the resting state and at least stimulation off and stimulation on with the same patient. Right? So that's already internal validation. I think that's nice. And I think the good thing about this data is that there's not much there, imaging data, because PET is the only possibility where you can do this. And imagination at MRI is not a good example. Don't even think about it, because I think imagination is, of course, people have shown in hand tasks about imagination, but that's, I think, is not a good way to do imaging. I would prefer better PET and really do the task.
Yeah.
If one would have a measurable biomarker such as this asymmetric patterning and so on, I mean, it might not happen when the patient is addressed. Yeah. That if it is a physiological function, and it's depending on commands, it should also have an address.
Yeah.
I was just saying it isn't possible for your patient because we showed previously that NFP, I mean, when NFP is increasing, it's related to Parkinson, or is it a marker for
This cellular oscillation or
yeah.
Yeah.
it's not a marker for freezing.
Also you need a marker for freezing.
Like freezing till now, there are some results that show, for example, freezing has the same problem here and also in electrophysiology. They take patients who freeze, patients who do not freeze, and try to find differences between them during rest. Then some of them try to make them walk, and they can find also some differences. Till now, there is one study, like the last published study in translational neuroscience. They were showing only 4 patients. They had different levels of freezing. The most freezing one of them showed very high beta peak during the freezing episode. And this was not translating to the other patients. And for the other patients that we saw, also it is the same. Because also freezing is not one thing. Freezing is a mix of different things. It starts with resting, with the rhythm of the gait, with the initiation. And the freezing episode is also different among patients. So a lot of these studies would say at the end, yeah, we found different results because freezing is a mix. And still, none of them was trying to differentiate between the different freezing items. But still, it's very difficult with this very little amount of patients. If you have 9 patients, it's impossible.
I think we would have tried to find biomarkers and at least in data. And do you think that it might be possible that it is not there in the brain? Otherwise, it develops in the brainstem and just goes down.
I think what is there actually in the literature is that the brain actually combines this with another task, let's say to do with orientation or that they need to walk in a certain pattern. Then, of course, there are biomarkers in the electrophysiology, like for example, alpha band also, and people have shown that there is some increase in alpha band in certain regions, like the ones which we showed. The parietal frequencies, that they are markers, but it's still, like he said, it's not extremely clear because always the issue is that we don't have patients who are, or at least many patients who are freezing episodes, and then we can record exactly at that time.
And we have no example where a provoked alpha oscillation causes freezing.
In a certain region, probably yes, but not generally alpha itself.
I mean, sure, it's
Yeah, it's a limitation that we see this activity also only during the freezing episode. We are focusing on the freezing episode, but actually accelerometers can predict the freezing before they happen. So there are stuff that are happening before, and the electrophysiology or the metabolic activity can't reflect this brief freezing time, because it is what is interesting.
where do they measure this brief?
I mean the few milliseconds that are before, like they are preparing the to the freezing
Because
episode.
where's the accelerator connected?
are the accelerometers. I mean, the accelerometers that are
not in the brain.
exactly. I mean that we can see the freezing is going to happen on the behavior of the patient, but we none of the studies worked on this phase or studying this phase for predicting freezing. Yeah. Any further questions? Thank you very much.